Thanks, Rob. Now, this is a pretty tricky topic I've been given to just cover in half an hour, like ethics of decision-making in complex surgery. It's something I've struggled with myself, both clinically and as chair of the hospital's ethics committee, because we all know what it's like, that sense of everything unravelling, the balls falling away. And I'm sure you, like me, will go home sometimes at night and you wonder, what's it all about? Now, when I spoke to my colleague, Dan Harvey, he says what he does often at 2 o'clock in the morning is he might go and have a little cup of tea. And that's how he sort of, cries over his cups of tea. But for me, being Australian and not really a tea drinker, so I go for something a bit stronger, which is a nice Aussie red. And we all have these struggles with these difficult decisions, and they're coming, societal expectation is driving that even forward. So how are we going to make better decisions with this topic? Because a big theme of mine as chair of the ethics committee of the hospital is this concept of moral distress. And it's that distress, that emotional reaction to the ethical complexities where you know what you think is the right answer, what you should be doing, but because of the circumstances, you're forced to do something opposite to what you think is right. Either giving an operation you don't believe is the right thing, or not doing an operation when you think it's the right thing. And this can affect patient and family satisfaction, and it's often driven by patient and family. There's team aspects that are at play in this. And what we are called upon more and more is to justify our decisions. Gone are the days where you can just say, I, the consultant, say so, and it is so. It actually, more and more, we were challenged by our colleagues, by our patients, the families, by the GMC, by societal, by the TV cameras. We have to write and be justifiable. And therefore we need to reduce the fallout that can come from these decisions and find a way that you're not turning to alcohol, cups of tea. I'd recommend tea over alcohol, or any of those things to reduce the fallout. And it can, in this topic, feel like a maze. But as you know from the London Underground, there are ways to navigate it. And once you start to practice that way, it becomes almost second nature, and it can help you until one of the tube stops, closes down for the moment. But anyway, you still find your way through. Now, you've probably heard myself and Dan Harvey talk about this framework for ethical decision-making, and we call it moral balance. I know because some of the audience have never heard it before, but many in the audience have. I'm not going to go through and talk about how we came up with the concept and all the underpinning aspects of it. We've started having a website to try to sort of promote it, and it's actually going to be in a BJA education supplement very soon. We're just waiting for the proofs for that. And Thea De Beer wanted me to tell you that for the CQC booklet, where we give them all the innovations we're doing and all the good things, moral balance appears in that. So take note, because if you get asked of something good or how do you make your decisions, say, moral balance. But so what I'm going to choose to do in my time is to take just a single case, work our way through it using this framework, and then we're going to modify some of the factors, and you can see how the balance changes. So it's late Friday afternoon, and isn't it always, where Brian, a 68-year-old morbidly obese male with a past medical history of smoking, hypertension and diabetes, comes in A&E with a ruptured AAA. He's awake and his blood pressure is unsupported. Clearly, this is high-risk surgery, but the patient, as always, is keen to give it a go. And your anaesthetic opinion is sought. And is he suitable for surgery? And it's a difficult, typical, complex surgical case. An emergency case, which is in many ways a large part of our work. What are we going to do? Do we go for it? Do we not? How do we justify that decision? Well, moral balance, we follow that framework. The first step, it says, is make sure of the facts. This can seem a really simple statement, but many times in the ethical decisions I come across, stepping back and going, well, what are the facts? What do we know? What do we don't know? Because the don't knows tell you where you may need to ask more questions, seek a second opinion, do another scan, what you should find out. So these are what I think are the facts. And I say that these are facts that are relative to the present problem. He's got a ruptured AAA. He's relatively stable. There's no real conservative option for a ruptured AAA. We can't really hope it's just going to go away. a bit of antibiotics and he'll be okay. Now, it could be amenable to an EVAR and versus an open surgery, and that is a question, because as you know in this audience, it will make a material difference whether it's an EVAR is being proposed and how difficult that will be, versus whether it's going to be an open procedure, and that will change the morbidity and mortality of that. We have some facts from his past. He's relatively young, 60-something, that's relatively young, but he's got significant comorbidities, and he's morbidly obese. And, what's his exercise tolerance? And when you sort of start to ask him that, you're even more appalled that he's sort of, he's bottom, ground floor, doesn't go upstairs anymore. Yeah, he can walk to the shops with difficulty, often in a wheelchair, big wheelchair that someone takes him in. But he likes TV and he likes talking to people, and he's a jolly old fellow, so it's pretty hard you're feeling pretty bad that you're thinking no. And we'll hear about frailty and its impact. And then you start to build in your mind what's the prognosis, and you can do things like pea possum, or you can just say, and this is the word that came out of my childhood when I was writing this talk, he's got Buckley's. Does anyone know what Buckley's is? Well, it's an Australian word. So William Buckley, was a convict in Australia, and he escaped, and he was in Melbourne, he thought that what he could do is he could walk just a few days, maybe a few weeks, he could walk to China. So that was his plan. He was going to walk to China. And now clearly people said, you've got no chance, you've got Buckley's. And it's a saying in Australia for no chance. You've got Buckley's chance, you've got Buckley's hope, you've got no hope, you've got no chance. And that's as I lay down the facts, I'm thinking, he's got Buckley's. This is not going to work. He's not going to get through this. So now we start to think about outcomes of relevance to the agents involved. So we've got this message, give it a go from the patient. He wants to live. And it's, he's a jolly fellow. It's quite hard to make that decision. But as we've seen, it depends how we explain it to families and to patients. Because what is often, our surgeons will talk to the patient and the relatives. They'll say, well, you can have surgery and, it's really high risk and you might die or you might get through it. And, in their head, it's like, well, I could die under anaesthesia and completely unaware, or I can take the chance and then I can recover. So it doesn't if you tell them you've got a 10% chance of getting through this or a 10% chance of dying, or you reverse it and say there's a 90% chance you're not going to make it, you're still going to roll the dice, aren't you? Because, death on the table, drifting off to sleep, versus that 10% chance I can live. When we know it's much more complicated like that. And really it's a Sudoku puzzle of life, of recovery and critical illness and complications, and then getting a little bit better and going back, and tracheostomies and Zassi's tubes for your bottom and all sorts of things, and back and forth and back and forth. And this is the complexity where he might end up, dead, which isn't necessarily the worst outcome, or never getting off, sort of high dependency and taking weeks there, or nursing home and not going back to the house that he said was, he may want to live in. And that's the complexity. So actually, it tells you we may need more information about him, more than just do you want to live, which the standard answer is yes. And that doesn't actually help you very much. But some of the other outcomes are relevant to him, and you might find this, is you learn actually that his father was an amputee from the war, and it really degraded his dad. And he is adamant he would never want an amputation like his father had. And that's a really important thing, because we all know these EVARs, AAAs, 2 days down the track, the next step is the amputation. And it may not help us make our decision now, but assuming he may lose consciousness and may not be awake for the next question, that's a really important fact we've discovered. And you find out that although we would think that his life in his watching his TV, midday TV, isn't necessarily a life that we would want for ourselves, he's quite happy with that, but he's adamant, I do not want to end up in a nursing home. I want to stay at home. If I can't live at home, I'd rather be dead. And you've established a really important facts about things that actually matter more than just living or dying, which is in some ways not necessarily very helpful. Of course, you try to involve the family, and his son's there now, and the comment comes back, he's a fighter doc, and aren't they all? And but the thing about moral balance, and when we will change some of these factors in a bit, it's something you can bring in. What do the surgeons think here? What's the impact on ICU? How are you thinking about this? What about the other patients? If we put all our resources into him, how does that affect? What about the wider NHS? And you can put in all of that. And this is a list of some of the other outcomes of relevance. And, mortality and morbidity are the common ones we just start to think about. But there's a whole host of them that are equally important and make a big difference. So things like metrics, complaints and litigation are drivers that we're often not quick enough to acknowledge in our own hearts exist. So the next step of moral balance is we start to level out the arguments using a balancing box. And this balancing box is just basically using those 4 principles we learnt at medical school and applying the facts and the outcomes of relevance into them to help us come to our decision. So let's try for poor O'Brien. So in the basically on difficult cases, I will draw a box like this and write in, and since I can't spell non-maleficent, so I just write burdens. So autonomy, give it a go, independence, non-amputation, okay? In benefits, there's this thing about, where's the chance, maybe what's the chance we may be able to save him? And, there's this also benefit that we gave it a go from the family. He's a fighter, let's do it, okay? All right, we are, and there's a benefit. But there's some burdens. This isn't going to be easy. This is going to be a prolonged hospital stay. There's something I like to refer to ICU mission creep. All that will give you 24 hours. It never works because Sarah will come along and she's, actually it's usually the opposite because she's more hawkish than I am. And we'll continue on and we know, he's a bit better today. Well, maybe we said we wouldn't filter him, but maybe we should filter him. And there's also that aspect. The burden we're really offering is potentially loss of independence. And then there's staff nihilism. It's depressing to do surgery, to do operations on people who are going to die all the time and just die slowly and in a way that doesn't feel very dignified. And of course there's justice concerns. The patients in ICU, the patients in the rest of the hospital, the cost. And what I do then, when I've got my balancing box, is I ask myself a few questions, and this is how I try to balance. I ask myself first off, is there anything of particular note? What's jumping out at me? And for me, it's the Buckleys. It's the mortality. Because, the benefit we're saying, it's quite unlikely that he's really going to save his life. That's why he's Buckleys. And, how long is this man going to live for? Like, are we really saving him or are we just deferring his mortality? Even if we got through that and even if we got him home, which seems really unlikely, is he? How many years has he got? His conditions is as bad as a terrible cancer. His 5-year survival is awful. But the problem with Buckley is that actually he found some Aboriginals and he lived happily with them for 30 years. So Buckley did all right, actually. And so there's always that problem with this, because you can say you've got Buckleys, but you don't always know what is going to happen, and people surprise you. And that's the problem with the uncertainty, and that's the problem with, there's no score that is going to give you the answer. And that's why you need to have a framework to weigh these things. So the next questions, I ask 2 other questions. Where is the greatest conflict? And this is where it can be quite powerful. Look for things that are on both sides in multiple boxes, and where is the greatest congruence or agreement? So for me, the greatest conflict is in this independence. It's in both. He wants to be independent. There's a huge chance we're not going to give him independence. And therefore matching those up, because they're in conflict, because we're not going to actually, what we're offering is loss of independence, really. And what he wants is independence. And we need to then talk to him maybe more about that, or at least put some limits in place of when we know. And then where there's the greatest agreement or congruence is give it a go, give it a go. And there is an overwhelming desire for that, and that's really hard to fight. So I think the days where we could go, is he suitable for surgery? No, he's not. Or, yes, surgery, I'll let ICU know and they can pick up the pieces. Those days are gone. From me as an intensivist and for you, when I did anaesthesia and for yourselves as anaesthetists, it doesn't help you just to say yes or no. You need to be able to justify it and need to be able to explain to others, to yourself at night when you're crying over your cup of tea, whether this was a good idea or not. And I think some of the things you may be able to write now, and I use my moral balance framework to help me write in the notes. So I start thinking, what's the facts, in particularly about prognostication? And you might write anaesthetic consultant in resus. I always write where I am. I find it, I've having written many, many coroner reports. It's so helpful if you write where you are when you're making that thing. And the fact that you are in resus with that person is very powerful to show that you're caring and that you're not just over the phone. And you might write something very simple, like Brian's a ruptured AAA and a background of life-limiting comorbidities. Even if surgically amenable to EVAR, the prognosis is extremely grave. Coroner reports look so much better when there's a narrative story. It looked like this was really high risk. I thought he wasn't going to make it. Oh, he didn't make it. Is much more powerful than, oh, it's all going to good. We're going to save your life. Oh, he's dead. That doesn't actually, that looks terrible. And so it's extreme. You're helping your future colleagues by putting your thoughts down on paper. And then you might want some of the family of outcomes of relevance. I've spoken to Brian, his son. Brian would like to attempt surgery, and he's fully aware of the risks. He values his independence, and because you've learned a bit more information, he's strongly against requiring nursing home care and also vehemently opposed to amputation. Were these negative outcomes all that could be achieved? Brian understands and agrees we should move to a comfort care approach. His son is also in agreement. Really powerful stuff you've just written. And I would urge you, get out of the pink chart. Pick up a piece of paper. This can't be written on an anaesthetic pink chart. This is a consultant opinion. I'm sorry, registrars in the room, but when you are one of those, this needs to be given some space. Maybe not pages and pages, as you'll see. There's not too many pages. And then the decision bit. Having discussed with Miss, whoever our vascular surgeon is, and the ICU team, because you bring in the MDT. No one wants to go to the coroner's court alone or to court alone. Bring your friends. You always want to have friends there, so bring in others. That's very protective of yourself. We plan to do the surgeon urgently with the aim of admitting to level 2. Deterioration from that point would likely represent an unsurvivable state or a situation that would result in the outcomes not in accordance to Brian's values, wishes and beliefs. You bring in those outcomes of relevance in. Consideration, not necessarily happening, but consideration for palliative care in that circumstance would be appropriate. I think that's a much stronger than yes for surgery, not for surgery. You're laying it. And one of the things I'm using more and more in my practice is this concept of yes, but. And this is how you can navigate some of these situations. Yes, we will do your surgery, but it'll be, if you get worse and you'll need level 3 care, it's not going to be effective. And this, it's easy to say yes to people and then put the provisos on than to just say flat no and basically you escalate a problem and escalate the conflict. Yes, but is a very powerful tool we should use more of. So what you see here is these ethical principles and how they can be applied. And I think it can bring clarity to difficult situations. It can help you make the right decision. It can aid you in your communication, where you need to go next, help justify them. And I think a better ethics is about having better justifications for our decisions. And what I want to do now is alter the facts and outcomes of relevance, because I want you to see how the framework for Brian will change as we alter some of the background. So let's alter some facts. So he's in the same, still Brian. He's now semi-conscious though. His blood pressure is 60 systolic with maroamidinol bolus. His lactate's 15. His last words before he became semi-conscious was, "Help me," which is, I hate that, don't you? I'll be all right, doc. Where does that sixth sense come from that I don't. Is this some sort of spiritual thing coming through? Because man, they freak you out, don't they? When they actually predict their own demise like that and or beg you for help, and it's not going to work. So is he suitable for surgery? Honk if you love Brian. Help me. All right then, I honk for Brian. And when we see this now. And when I go through them, we lay out, he's got that autonomy, help me. We don't know much else because he's semi-conscious. The thing that jumps out immediately is, crossed out. We're not, it's not just unlikely. He's dying, and there's nothing we can do about it. And, where is the greatest conflict? Is probably now between autonomy, his help me, and justice. We can't help you, Brian. You're dying. And actually, I could pour all my effort now into you, but that's at the detriment of everyone else now, who also are saying a little help me. Maybe they haven't vocalised it yet, but they'd like you to help. And there's nothing we can do now. And we write in that circumstance to say and talk to Brian's son and talk, Brian's your father's dying, and there's nothing we can do. And I think you can see how that clear fact change has altered where the balance lies. Okay, let's do another one. So 6 months ago, we know we've got his AAA. He was assessed for elective surgery, and the decision was made he's not fit for surgery. You heard this one before? Yeah. And now he's in your A&E with a ruptured AAA. And this is a great quote. He found that it was easy to make a heroic gesture. They're not fit for surgery, but hard to abide by its results, which is like, oh, he's here now. And you can sense that, can't you? That we said he wasn't fit, but now he's dying. And where can we said that, and now can we abide by it? It's really difficult. And I think the moral balance framework brings that into real clear. So when you think about anything of particular note, you've still got the fact is we said he wasn't fit. We said he wasn't fit, and now he's here with a ruptured AAA. We probably should be saying he's still not fit. But if you think about it in terms of where some of the greatest conflict is, it's really comparing that the past and the present from his understanding of the time, and his thoughts now, which might be a help me, and that huge thing, and I've added into the balancing box there because it's really coming out of it, that we gave it a go from the surgeons. And this is what you're up against. The facts of the matter about the prognosis is potentially now not as strong now, because you've got this enormous weight of guilt and desire to do good that's coming from the family, even though they get it intellectually that he wasn't fit, and from our surgical colleagues, because that cry for help is so strong. And sometimes you can take this, because this doesn't tell you exactly what to do, it never has, but it tells you why you might think it's quite clear we shouldn't do it, but you can help understand why the surgeon is struggling to say the same words, even though they were the one who said he wasn't fit for surgery 6 months ago. And you feel that, and it's very difficult. And at least it helps you understand why we're in this situation, and why you may go, all right, we will give it a go. And then you try to put as many limits into his place and as much sense in you can, but you can at least see where people are coming from. That desire to rescue is a really sort of human impulse, and it can be hard to oppose. And that's, you need careful communication if you are going to oppose it. Okay, next one. So he's known AAA. He was being worked up for surgery, but it appears that due to staff changes and an admin mess-up, he did not get a pre-op appointment and his case was lost. So this is a real iatrogenic cock-up. And so, and now he's here. And, surgeons are human beings, and we've joked about the fact that surgeons are often on the Kubler-Ross stages of grief in their, denial. What do you mean he's not well in the ICU? In your anger, well, if you'd only given more fluid, less fluid, more fluid, whatever, this wouldn't be happening. Bargaining, keep him till Monday, we'll do a CT. Depression, all my anastomoses break down to acceptance. I've spoken to Mrs. Smith, as husband, and yes, we think we should stop. So, once you realise your surgeons are human beings and on this journey, then it helps you understand them. But so it is with guilt and iatrogenic injuries. Why do we do more to those who've had an iatrogenic injury? Because we feel guilty, and it's a powerful motivator. And it can be very hard for us in anaesthesia and ICU to stop that. And sometimes we admit to protect the hospital, or protect individuals, colleagues, so that at least one aspect, we did everything we can, is a powerful message to the family, to the coroners, and to ourselves at 2 o'clock in the morning. So when you look at this, you can sort of see in bold that give it a go from the surgeon, is really the greatest agreement. That is almost overwhelming, that you're going to, despite all your fears, that you're going to end up doing this surgery. But at least you can help document some of this aspect. With a high risk, I'm not expecting to get through, but we all feel we just need to give it a go. You can even say those words. It's hard to argue against them. And the final one is just how we change one of the facts or outcomes to relevance again. This is a growing one, and one of the vascular surgeons came to the ethics committee to talk about a very similar case, and it's a growing problem. So it's a rupture that's been in a nearby hospital, but the patient and family is told he's going to have surgery in Nottingham. I spelled Nottingham wrong, sorry about that. This is his only chance to save his life, and he'll die without surgery. And it feels like this: the tsunami's coming down, and you're there going, I don't think surgery is a good idea. And it's like, it's not going to work, is it? And the surgeons feel this, and this is why the vascular surgeon came to the ethics committee. He says, I feel like they've arrived, everyone knows that they're going to have surgery. I don't want to do surgery because it's not going to work, but the momentum behind that wave is too hard. And I think we're guilty of this, and particularly in intensive care, where we say, well, they can't come unless you're going to operate, because we want to protect our beds. So why do they come if you're not going to operate? But maybe the mindset will have to change in the future, which is they're coming, don't tell them they're coming for surgery. Tell them they're being sent to the tertiary hospital for assessment. Surgery may be one of the options. And maybe that's where we need to move it to. So that actually we give tertiary opinions rather than basically being, a mechanic or someone who just does the procedure and doesn't think about it. And maybe we need to change that mindset, because it's really impossible, because you've got really clearly here that conflict going between giving it a go and all the factors. It's a waste of time. And we've had a patient who died in recovery, or maybe just made it to the ward, who we know hours of vascular surgery, who then was like, well, why do we do that for? And it's sort of from that case that the ethics committee was involved, just to talk through the burdens of this. And you can sort of see that this might be something we need to tackle on a wider basis. So this is where we're up to. I do hope those who use moral balance, it's a very simple technique. It builds off what you know, but it can actually help you work out where you should invest your time. It is hard. There's no simple. Our patients are complex. Our society is complex. Our society is quite divided. We've got half the population wants to bring in euthanasia, and the other half won't ever let you withdraw. This is the sort of divided society we live in. Moral balance is just a framework, but it's a tool that can be useful. Starting with the facts can be really helpful. It helps you recognise all the outcomes, can focus your communication, and can build trust and keep the team together. So that when you come home in the middle of the night, and you're thinking, is it the tea or is it the heavy-duty Australian red? And you might go, no, I'm happy. I made safe clinical decisions today. I delivered a standard of care that I would wish for myself and my family, that on my watch I protected the other patients under my care, that I may even have benefited other patients in society who are in need, and I maintain my relationships with my colleagues. I'm going to go home and go back to work tomorrow and drink coffee and do good. Thank you very much.
Thanks very much for that.